As we move proximally, the uniqueness of each zone diminishes, although there are some unique characteristics. We all know that these zones are discussed far less than Zone 1 and Zone 2, and that's simply because there's less impediment to regaining glide in these areas. But let's take a look. In Zone 3 through 5, what is unique? Now that we've moved proximally, all the joints affect glide, and in particular now the wrist comes into play. The wrist is the largest joint which the flexors cross, and therefore motion of this largest joint would have the greatest effect on glide in the proximal zones 4 and 5. Now, as we look at the protocols that have been suggested, and we look at the Kleinert protocol with the rubber band traction, the Brooke-Army or Palmer protocol where there's a pulley in the palm but there's still the rubber band traction, and then we look at the synergistic protocol which utilizes tenodesis and allows finger flexion with wrist extension, finger extension with wrist flexion. Of these three protocols, the one that includes the wrist becomes more relevant as we're thinking about the more proximal zones. In a study in 1992, Horry and Associates looked specifically at the total excursion, here in millimeters, of the FDP, the FDS, and the differential between the FDP and FDS. The Kleinert, Palmer, and synergistic protocols were compared, and you can see here that the synergistic protocol creates the most total excursion in all circumstances. In thinking about Zone 3 and 5, we know that initially 16 millimeters of glide is not necessary, but as we're working toward the end stages of rehabilitation, recreating maximum glide is very important, and therefore including wrist range of motion as part of your exercise routine becomes very important in Zone 3 through 5, whereas it was less so in protocols for Zone 1 and 2. Wrist range of motion can be included in the exercises regardless of whether or not you choose a synergistic orthosis as your design for the postoperative care. If we highlight the 3 to 5 millimeter zone of excursion, we can see that for FDP and FDS glide, that any and all of these protocols reach the minimum. But with the synergistic approach, the maximum is obtained. Just a reminder that Zone 3 is extrasynovial. There are no pulleys within Zone 3. This is the palm. There is peritoneum, which is the covering around the tendon that gives it its nutrition. But the nature of this peritoneum creates greater friction than compared to the synovial zones as we've previously discussed. In Zone 4, under the carpal tunnel or the transverse carpal ligament, there is also synovium, and therefore the subsynovial connective tissue does offer less friction than in Zone 3, but not as low as in Zone 1 and 2 as discussed. In Zone 4, we have a compact arrangement of the superficialis, shown here as with highlights, and the profundus tendons within the carpal tunnel. I have seen a video of an ultrasound of these tendons during normal active finger flexion and extension. These tendons do not just glide distally and proximally, but they actually move in relationship to one another, some moving above, some below, during active finger flexion and extension. So the amount of movement and the amount of differential movement between these tendons is significant. As we said in Zone 4 and 5, wrist motion is needed to establish glide of the repair site. We go back to the initial goal of establishing glide of the repair site relative to its bed. If then the repair site is in zone 4 or 5, we need to move that repair site relative to the bed by moving the wrist. Now the FDS is very interesting as we think about these more proximal zones. It normally, as a muscle tendon unit, is very erratic in its participation in finger flexion. And it actually does not always work as a concurrent force with the FDP. It has some significant independence. But it is recruited during finger flexion if power is required, and it is also interestingly recruited if the wrist is flexed. Therefore, I wonder if we would perhaps consider, instead of a neutral wrist posture, perhaps consider a somewhat flexed posture when working for glide of the FDS. So if we look at zone 3, here compiled are all the variables that would affect a flexor tendon repair within zone 3. Rather than reading these to you, they are available as part of your handout for you to retain. The same is true of Zone 4, which reviews all the conclusions related to each factor of the flexor tendon. And we have additionally included for you the information for Zone 5. We've reviewed this thoroughly already, but here it is in one place for your reference. Now that we've come to the end of this presentation, let's take a few moments and review the important points we've discussed. The ideal is for you to know as much as possible specifically about the surgery, to know about the suture, what type, was it a quality repair, did the surgeon feel confident about the repair, was there tendon gapping observed, were the pulleys altered in some way, was it a wide-awake procedure so that every aspect was observed and assured to be such that it allowed unimpeded glide? And most of all, what was the exact movement necessary for desired glide observed in the operating room? If all factors are ideal and there are no complications, therapy should be begun between 3 and 5 days post-surgery. And the first thing that we should do as therapists is determine whether or not this specific patient with this specific set of circumstances is appropriate for early active motion. Therapy always begins with passive range of motion first, regardless of the protocol. And if active range of motion has been chosen, it is important that initially that range of motion is partial. We want to move the sutures relative to the surrounding bed. And to do that, the joints distal to the tendon repair need to be moved through an active range of motion. In Zone 1, that includes the DIP joint. Zone 2, it is both the PIP and DIP. Zone 3, obviously it's all 3 joints of the finger. And Zone 4 and 5, the wrist is included. We reviewed information that 15 degrees of flexion at the MP joint provides the minimum amount of resistance to flexion if there's active range of motion. In the orthosis, if there is too much MP joint flexion, you are encouraging both interosseous and lumbrical muscle tightness. You're creating a posture for the patient that makes it very difficult to initiate with the extrinsic flexors. And because the patient is moving passively through range of motion, full MP joint flexion is not necessary to protect the collateral ligament of the MP joint. Active range of motion occurs to maximum only when there's no resistance and only as one progresses through the timeline post-surgery. In Zone 1 and 2, I would tend to place the wrist at 0 in the orthosis, but the more proximal zones need more protection at the level of the wrist, and therefore I would choose 30 degrees or more of flexion. Often the position of the wrist in zone 4 and 5 is dependent upon an associated nerve injury. In the information we've reviewed, we would suggest that extension of the finger, all three joints of the finger, is safe with the wrist at 0 degrees if the laceration is distal to the lumbrical origin, and if there are no complications. In other words, there's been an adequate repair and the wound status is normal without infection or complication. The goal in therapy should be to maintain full interphalangeal joint extension. That should be an initial goal and should be maintained throughout therapy. Therapy begins with only a partial range of active flexion, and that range increases slowly, and it increases only as the resistance dissipates. To regain full glide of the flexor tendons within zone 1 and 2, as well as full differential glide, one should, as early as is safe, concentrate on an active hook posture for glide within zones 1 and 2. Most of all, during your treatment of your flexor tendon patient, identify the variables that you're dealing with. Gather and report your data on outcomes so we can all learn from each other.